Okay, guys. So yeah, I was talking about hematology. I'm going to expect around 8 to 10 questions at least in your INICET. So let's start with this. Good evening. Good evening. So let's start. Yeah. So let's start with first question. First question is CASGEVY is a newly approved therapy. It is a new therapy approved for treatment of what? Yes, guys. So this is I would say current affair questions basically, so the new things that have come, that is what is a question coming here. So CASGEVY is a newly approved therapy for what condition? Yes, anybody knows? Let me see how many of you got it correct here. CASGEVY, it is a stem cell therapy available. So this is a stem cell therapy that is available for treatment of sickle cell anemia. Yes, it is for treatment of sickle cell anemia. So CASGEVY is a stem cell therapy. There is one more. So first we'll talk about what is this CASGEVY. So CASGEVY, yes. So CASGEVY is Cas9 or CRISPR-based technology. So few questions can come from this. So it is based on CRISPR. So CRISPR-based technology. So what do? We insert this and this cuts the, yes, it will cut. CRISPR will end up cutting the DNA. We all know that. So it cuts the HbF suppressor gene. So what is HbF suppressor gene? All of us are having HbF suppressor gene which has suppressed our HbF production. So it's a CRISPR based technology. Yes, so it's a CRISPR based technology wherein we are using we cut the DNA, and that cutting the DNA, what DNA we are cutting? We are cutting a HbF suppressor gene. So once we are cutting this HbF suppressor gene, this leads to increase in HbF. Increased HbF leads to decreased sickling. We all know this, right? So this is one. Another therapy that is in sickle cell anemia, newly approved by US FDA, that is your Lyfgenia. So Lyfgenia is also, only thing is it is a viral vector. So it is a lentiviral vector based. It is lentiviral vector based therapy. So what we are doing in this lentiviral vector based therapy, we are inserting a gene. So using this viral vector, we have now inserted, so inserts, this will insert another HbA gene. And this new HbA gene is HbA-T87Q. We call it as HbA-T87Q, wherein if we insert a new gene, so inserts a new gene, extra HbA gene is there, and this will end up increasing in HbA synthesis, and thus there will be decreased sickling again, right? So there will be decrease in sickling happening. So these are the two therapies available for sickle cell anemia, and both of these have been approved by US FDA, and that is why more likely to come as question here. Okay, yeah. So that is the answer to question number one. So question number one, CASGEVY was a Cas9 or a CRISPR based technology. Next, question number two, a patient presents with easy fatigue, hemoglobin is 9, hematocrit 31, reti count 10%. Reti count 10%. What is the reticulocyte index of the patient? So examiner is asking you RI of this patient. So what is the reticulocyte index? RI or RPI also we call it, right? So RI or also called as RPI, reticulocyte production index. So what is the no, not yet available in India. So what is the RI, RPI? RI or RPI? So reticulocyte production index is equal to, formula if you remember, CRC divided by maturation time. And maturation time, we will come to that. So maturation time will be based on hematocrit, if you remember. More than 40 will be 1. Between 30 to 39.9 it will be 2. Maturation, not 2, sorry, 1.5. And between 20 to 29.9 it will be 2. Less than 20 will be 2.5. So these are the different maturation indices. What is maturation index? How much time it will take for maturation in the peripheral blood. That is what we are looking at, right? How much time it is going to take for maturation in peripheral blood. So these are the different maturation indices. Now, so but what is CRC formula? So let us first talk about CRC, then we have to calculate CRC. CRC is patient's hemoglobin divided by patient's hemoglobin into retic count of the patient divided by 15. So what is the patient's hemoglobin here? 9 into retic count. What is the retic count given to us? 10 divided by 15. 5 2s are 10, 5 3s are 15, 3 1s and 3 3s. So my CRC is 6. So this is not the answer. This is CRC. Isn't it? Very good. So now what should I do? So Ri is equal to CRC divided by maturation time. 6 divided by, what is the maturation time? Hematocrit is 31. So that is why maturation time will be 1.5 days, which is equal to 4. Actually it is 4, but none of the values are giving me of 4. So the nearest value I'll answer it as what? Option B, 4.5. Yes, you are right. Intentionally I did not give a value of 4 here, so that you still have to make a diagnosis like this. And in exam it happens, frequently it will happen that nearest value will have to be, or the best, whatever is the best possible answer you have to mark, right? Yeah. So remember, exam, they might ask CRC or they might be asking RI as well. So depends what examiner is asking. Based on that, you're going to answer. Okay. Next, question number 3. Sickle cells are. So what about sickle cells here? Sickle cells are osmotically more fragile, mechanically less fragile. Osmotically less fragile, mechanically more fragile. Osmotically more fragile, mechanically more fragile. Osmotically less fragile, mechanically less fragile. Option 4 was not in the option. Which one? 2%? No, that is not the case. Yeah, what is the answer? So sickle cells, remember first thing, any extravascular hemolytic anemias have to be mechanically more fragile. They cannot be mechanically less fragile, isn't it? See, if they are mechanically less fragile, then they will not die in the spleen. So answer will be mechanically more fragile. All sickle cells, thalassemia, hereditary spherocytosis, even G6PD, all these are mechanically more fragile. That is why they get killed in the spleen. In G6PD, predominantly lysis happens although intravascularly, but any extravascular which is happening in the spleen, they will be mechanically more fragile. That's why they are getting killed in the spleen, isn't it? Okay, so mechanically more fragile. So A and D are already what? Ruled out. So अब मुझे बताओ, osmotically they are more fragile or osmotically they are less fragile? Answer for sickle cells are osmotically less fragile. Sickle cells and thalassemia, they are osmotically less fragile. They are osmotically less fragile. Whereas hereditary spherocytosis, or we can write spherocytes and elliptocytes. Spherocytes and elliptocytes are osmotically more fragile. Osmotically more fragile. Of course, spherocytes and elliptocytes are also mechanically more fragile. Remember this. Spherocytes and elliptocytes are osmotically more fragile, and mechanically also they are more fragile. Isn't it? Yes. So this is the question. Sickle cells are, yes. Next, question number 4. Question 4. Advantage of ferric carboxymaltose, FCM short form we call it, over iron sucrose or iron dextran is. So what is advantage of ferric carboxymaltose? Mechanical fragility is nothing but because they are mechanically fragile, they get trapped in the spleen and they are killed in the spleen, isn't it? So anything which is undergoing lysis in the spleen has to be mechanically more fragile. Mechanically more fragile. Yes. So what is the advantage of ferric carboxymaltose over iron sucrose or iron dextran? Iron sucrose, iron dextran, all of these are IV drugs only. All of these are parenteral. So answer A is not the answer. Because A is not the answer, D is also not the answer. Yes. So D is also not the answer. Even in thalassemia also they are mechanically more fragile and osmotically less fragile. Mechanically anything which undergoes hemolysis in the spleen. So in beta thalassemia, if you are asking me, they are killed in the bone marrow itself, but whatever are going to survive, they will also get killed in the spleen. Primarily lysis happens in bone marrow, but small amount of lysis happens even in spleen there. Okay, less toxic or more compliance? We have to select one. Very good. Answer is more compliance. Why? Ferric carboxymaltose, or yes, basically it is a iron maltose, we call it iron maltose. So iron maltose is a single dose iron. Single dose IV iron is given. Single dose IV iron is given, and in this there will be 1000 milligrams of IV iron in. So 1000 milligrams of IV iron in single setting, single injection. So basically in single infusion, 15 ml infusion, we end up doing it. So we need not call the patients again and again. So for iron sucrose and iron dextran, we cannot be giving 1000 milligrams. We can be giving only around 200. Iron sucrose we can give 200 milligram in one setting, and that is alternate day we have to be keep giving that. And that is what is the biggest advantage of FCM or iron maltose, or iron maltoside also is available, right? So that is the advantage. So that is why it is more compliance is there. So single dose, that's why compliance will be more. Yes. Now toxicity, it will be same. So you cannot keep giving multiple amounts. So obviously it is 1000 milligram single IV iron. So still you will calculate Ganzoni using Ganzoni formula, how much is required iron. And if it is less than 1000 milligram, do not be giving that. Okay, it should be more than 1000, then only you will be giving it. And also say suppose if total requirement comes to be 200 milligrams, then you will call the patient in two different settings, and you will end up going to finishing in 2 doses. Otherwise, if you are giving iron sucrose 200 milligram, you have to give, that means for 2000 milligram you have to be giving in 10 settings. Okay, yeah. So usually for most of the people, what we do is we just give a single dose, and then after that we keep giving them orally. Okay, if there is absorption happening, if of course malabsorption is there, we have to keep giving them IV, right? Okay, next, a patient is having hyperpigmented knuckles, easy fatigue, hemoglobin 8, MCV 110. What is your diagnosis with this? Macrocytic anemia with hyperpigmented knuckles. I am suspecting vitamin B12 deficiency, isn't it? This is more than enough for me to suspect a vitamin B12 deficiency. A special test is performed in which oral radio labeled vitamin B12 was administered. So oral radio labeled vitamin B12 was administered. This itself, they are talking, examiner is talking about what test is this then? This special test is nothing but they have done a Schilling's test, isn't it? This is a Schilling test they have given to us. Okay. Yeah. And it was found 5% of the administered B12 is excreted in urine. So what is the cutoff here? 5% is, so the cutoff for excretion, we keep looking for what? 10%. If it is more than 10%, then we say absorption is happening. Or if more than 10%, absorption present. If it is less than 10%, then absorption is negative. So this patient did not have absorption. It is only 5%. That's why absorption did not happen. So if absorption did not happen, yes, correct. So if it is more than 10%, we call it absorption has happened. If less than 10%, there is no absorption. So if there is no absorption, it is, so now my diagnosis is malabsorption of B12, isn't it? So patient is having malabsorption of vitamin B12. That is my diagnosis. So it cannot be iron deficiency, dietary deficiency there. Pernicious, yes, it can be pernicious. Ileal ulcers also cause malabsorption. That is the reason why option will be option D. Very good. Many of you got it correct. Option D. Ileal ulcers will also cause malabsorption because absorption of B12 happens in terminal ileum. Ileal ulcers commonly happen in Crohn disease. Crohn can have ulceration in the ileum or any cause of ileal ulcers. Even a TB might be causing an ulcer in the ileum because intestinal TB is also very frequently ileocecal tuberculosis, isn't it? Yes. So that is the answer to this question. Option. Okay. So if it was more than 10% here only, then answer would have been what? Dietary deficiency, right? Yeah. Next. Question number 6. Let me see how many of you got this correct now. Yeah. So this is a patient is being investigated for some hematological condition. He is CRAB negative. And following is the electrophoresis image. what is the likely inference? What is the likely inference? Okay, the moment it is CRAB negative, we're unlikely thinking of what? Multiple myeloma. Almost we rule out multiple myeloma here, isn't it? We almost rule out multiple myeloma. Okay, yeah. Now, next, what else is there? Okay, and there is the electrophoresis given. Can you understand now what is the electrophoresis? This is your patient specimen that has been given to us, okay, and they have mentioned IgG, IgA, IgM, kappa and lambda. Actually, this is a serum electrophoresis. If you are looking at serum electrophoresis, if you remember, I had shown in the serum electrophoresis in such a graphical manner also. Yeah, that will be what? Albumin, first one, then alpha 1, then alpha 2 was there, then beta was there, then gamma fraction was there, if you remember, right? So this is how I had shown you. Same thing will be here, by the way. This will be albumin, this will be alpha 1 fraction, then alpha 2 fraction, then beta fraction, then gamma fraction actually. So when we are looking at like this, so this is your albumin fraction, okay, like that. So what is happening in this patient? Let us look at this patient now. What you're finding here, IgG, gamma fraction, there is a IgG, not a very strong band, but there is a IgG present. Okay, now I'm looking at kappa and lambda. Kappa is also positive. Yes, kappa is also positive. Lambda is also positive. Lambda is also positive. I can see, although lambda is very faint, that means of course kappa is more strong and lambda is less stronger. But however, now does it make monoclonal? No. So if it was monoclonal, you would have seen one, there would have been, ideally there would have been a band here. Okay, if it was monoclonal, I'll just try to show you how monoclonal would have appeared. It would have appeared as a band like this. Okay, it would have appeared like a band, and it will be only in one, not in the other one, right? Yes, so this is not monoclonal. So what does it say? Both kappa and lambda positive. This says me it is polyclonal. Polyclonal. So polyclonal, it is not MGUS, it is not smoldering myeloma. If it was monoclonal with CRAB negative, I would have called it either MGUS or smoldering myeloma, isn't it? Anyway, to differentiate between them, I should have known the M protein level and the plasma cells also in the, yes. So answer is, this is a non-neoplastic. It is not a multiple myeloma. So it can be any other cause like an infection, reactive condition where there will be what? Elevated immunoglobulins happening, right? Yeah, any chronic inflammation or any chronic condition can be causing such a manifestation. Okay, so how did I identify it as a polyclonal? Both kappa and lambda are there, right? If it was monoclonal, there would have been a single band. Only either kappa or only lambda would have been there. Okay, next. Question number 7. Flow cytometry of a patient is as follows. What is the likely diagnosis? Okay, what markers they have given? In one marker 23 and 5, in another marker 20 and 10 they have given. Okay, tell me now interpretation. Look at this. Most of these cells are, yes, from this I can say they are CD5 positive and they are also CD23 positive, isn't it? And from this image I can see definitely all the cells are CD10 negative. All the cells are CD10 negative and some of them are CD20 positive. Some of them are even CD20 negative also. I can see that. So that means these would not be your neoplastic cell. Probably these are the one, isn't it? Yeah. So tell me now, majority of the cells are CD5 positive and 23 positive. In fact, some of the cells are 23 negative also. You can see here, these are CD23 negative. This will actually be corresponding with, these CD23 cells will be corresponding with CD20 negative also probably, right? Yes. So what is your diagnosis here? Yeah, very good. It is 5 positive, 23 positive, CD20 positive and CD10 negative. Answer is BCLL. Very good. BCLL. Okay. Yes. So how to interpret? Already I have taught to you guys in DVT and other places, even in class also. So how do you interpret? Okay, whatever is on the x-axis, look at this line, the vertical line that I am drawing now, this vertical line, right of this will be positive, left of this will be negative, isn't it? Left of this line will be negative. Similarly, the horizontal line, above this will be positive, below this will be negative for this marker, whatever is a marker that is plotted here. Okay, yes. Next, question number 8. Question number 8. Which of the following scenarios qualifies as AML according to the WHO guidelines? So, smoldering myeloma, because smoldering would have been monoclonal there. No, this is polyclonal. So, it is not even MGOS. It is not a neoplasm at all. They should have been monoclonal there. Right? Next, which of the following scenarios qualifies as AML according to the WHO guideline? If you remember, for definition of AML, we have two criteria. What are the two criteria for definition of AML? One, either the blast count in the bone marrow should be more than or equal to 20%, or second criteria is blast carry any genetic abnormality except for translocation 922. Another one has been added to this, CEBPA mutation. So except for these two, any genetic, if it is there, that will be qualifying for AML. Okay. Yeah. So let me see now which one is it. Okay, let me see how many of you got it correct here. Okay. So 22% blast without any genetic abnormality. Will it be called as AML? Yes or no? Yeah, this will be called as AML. 15% blast with translocation 922. No. Why? Because exception was there. What is that exception? 922. So this is not AML. So this is false. 15% blast with translocation 821. This will be called as AML. Correct. 15% blast with translocation 821. Next, 15% blast with inversion 16. This will also be called as AML. Next, 20% blast with translocation 922. Okay, translocation 922 is exception, but however, this is qualifying for my first criteria. Blasts are more than or equal to 20%. So this is also AML. Now, many people, yeah, have answered it. Many of them have answered it A, many of them have answered it B. So answer is not A, answer is B. Now, why is the fifth one AML? Fifth one is AML not because of genetics. It is AML because of blast percentage. It is because of blast percentage. In fact, 20% blast, this would be called as the fifth one. This will be called as, we call it CML-BP. CML blast phase, which is nothing but CML progressing to AML. CML-BP is nothing but CML progressing to acute myeloid leukemia. I'll repeat again why fifth one has become into AML. Not because of genetics. It has become into AML because of blast percentage. Blast percentage is more than or equal to 20 in that. And that is the reason why that is a AML. That will be treated as AML only. Okay. Answer is 1, 3, 4 and 5. 1, 3, 4, 5. B is the correct answer. Next. Okay. A patient's hemoglobin is 17, RBC count is 6.5 million, MCV 80, MCH 29. What is the next line of investigation? Iron profile, JAK2 mutation, serum erythropoietin and HPLC. Yes, please tell me now. What is the correct answer to this? Iron profile, JAK2 mutation, serum erythropoietin, HPLC. Let me just tell you, RBC count is high. What all I can suspect? I can suspect thal minor or polycythemia. So I can suspect two things, polycythemia and thal minor. Important point to be noted. Yes, in the same question, look at this, I will twist. Hemoglobin is 12. What will be the answer? Tell me now. In the same question, if I make hemoglobin 12 and MCV little bit less, say 70, what will be the answer? Yeah. Okay, very good. In this case, hemoglobin is 17. Hemoglobin is 17. So definitely it qualifies more than 16.5. It qualifies for thalassemia, isn't it? Yeah, sorry. It qualifies for polycythemia. So the diagnosis here is polycythemia. What is the next line of investigation? Now tell me, is it JAK2 or is it erythropoietin? Tell me now. JAK2 or erythropoietin? Is it JAK2 or erythropoietin? If that is the case, tell me what will be the answer in this case. Yeah, in this case, we'll come to the subsequent one, discuss later on. Yeah, tell me, please tell me now, JAK2 or erythropoietin. What is the next line of investigation? Erythropoietin. Why? Because erythropoietin helps us how? Decreased EPO or increased EPO? Tell me, what are you thinking? Decreased EPO, increased EPO. What are you thinking? Decreased EPO is polycythemia vera. Increased EPO is secondary polycythemia. Yes. Now, why not JAK2 mutation? That is my next question. Somebody asked B also. Somebody said B. Tell me now. JAK2 mutation positive means what? Negative means what? If JAK2 mutation is present, then what is it? Negative, what is it? If it is present, PCV, correct. Negative means it could be PCV or it could be secondary polycythemia, isn't it? Negative will not make a difference. That is the reason why my next line of investigation cannot be JAK2. Yes. So erythropoietin decreased in primary. Primary is polycythemia vera, isn't it? Yes. So JAK2 cannot be my next line of investigation. Why? If JAK2 comes out to be negative, I will not be able to distinguish whether it is a primary or secondary. So that is why it is not the answer. No, it is not the answer. Okay. No. Negative doesn't mean no PCV. Negative 10% of polycythemia veras are negative for PW नहीं है यार, PCV, polycythemia vera. 10% of polycythemia veras are negative for JAK2. Negative for JAK2. Okay. So answer is not JAK2 mutation. Answer is what? So in this patient, how do I typically progress? How do I progress? Let me tell you. In this, first I will do what? EPO. So what if EPO increased? What if EPO decreased? If EPO is increased, I start look for secondary polycythemia causes. If it is decreased, then I will do bone marrow aspirate. Further, I will do JAK2 mutation. So this is how I'll be approaching this case. So first I will do EPO. Next, if it is EPO is decreased, then I'll be doing next investigation bone marrow. Then I'll be doing JAK2 analysis. Best investigation also cannot be. Best investigation also cannot be JAK2. Okay. JAK2 is the last investigation that you will be doing here. If they had asked which of the following is the best investigation to confirm it is a polycythemia vera, then only you will answer it as JAK2. Unless they are telling you it is polycythemia vera, you will not be able to answer it as JAK2. Okay. 5 and 23 positive, no mantle cell lymphoma. Concept 5 mantle cell lymphoma will be 5 positive, 23 negative. Okay. Mantle will be 5 positive, 23 negative. Next. Question number 10. Factor 5 leaden mutation. Yes. Factor 5 leaden mutation. So what is this factor 5 leaden mutation? It is the most common cause of thrombosis. We already know. Yes, correct. Most common cause of inherited thrombosis. Correct. Inherited thrombosis. What happens in factor 5 leaden mutation? Very good. Is it deletion of factor 5? No. It is nonsense mutation? No. It is point mutation. Correct. Ideally, I should have got a missense mutation. If that was the case, I would have answered it. Silent mutation? No. So it is a point mutation. Factor 5 leaden mutation is actually a missense mutation. Missense mutation at, this can be asked now, 506th amino acid. So in 506th amino acid, there is a change from arginine. So arginine to glutamine. Arginine to glutamine change will be there. And because this change, yeah, it is a missense point mutation, change to arginine to glutamine. And because of this change, because of this change, factor 5 becomes resistant to proteolysis by protein C. So normally your protein C should have go and lyse the factor 5. That is not happening because there is a missense mutation here, right? There's a missense mutation. Next, in a patient with thrombocytopenia, which of the following will be abnormal in TEG? In a patient with thrombocytopenia, which of the following will be abnormal in TEG? Yes, sir. What is abnormal in TEG? R value, K value, MA, LY30. Answer very good is MA because, yes, correct. Primary plug is measured by MA. R is measuring what? Secondary plug. K is measuring conversion of fibrinogen to fibrin. Only one step. Fibrinogen to fibrin conversion is measured by K value. LY30 is measuring fibrinolysis. Isn't it? Yes. So answer to this question is C. MA measures platelet count or platelet function basically. So if platelet function is reduced or platelet count, or we can say primary plug, it measures primary plug. That is both platelet count and function of platelets is measured. Okay. Yeah, what is TEG? TEG will be a graph like this. If you remember, TEG is a graph like this. So tell me now what all things are there in TG. Let me try to explain. This is your R value of TG. Then there will be one more here. 20 millimeter clot will be formed. This will be K value. This is the K value. Then we have this is your MA, maximum amplitude. And then after 30 minutes of MA, so there will be after 30 minutes of MA. So let me try to show this is 30 minutes. Then this is your LY30, lysis after 30 minutes, right? So this is what is your TEG. So in TEG, R measures secondary plug. That is nothing but coagulation formation. K measures conversion of fibrinogen to fibrin, or we call it clot kinetics or clot polymerization. Then MA measures primary plug. So basically it measures how many of them. Then next is LY30 is measuring fibrinolysis. One more is there is an angle created. This angle is alpha angle. Alpha is confusing. Just remember alpha is inversely proportional to K. It measures just like K only. Only thing is values will be opposite. Okay. So alpha will be opposite. So if R is increased, then coagulation factor deficiency. Then K is increased, then decreased fibrinogen. Then MA is decreased, then either decreased platelet count or decrease in platelet function. LY30 increase hyperfibrinolysis. LY30 is reduced, then hypofibrinolysis, of course. LY30 is decreased, then it is hypofibrinolysis. So hyper and hypo. Okay, hyper and hypofibrinolysis. Alpha is exactly opposite, not exactly opposite. Alpha measures fibrinogen only, but it is value will be opposite. So K is increased, alpha will decrease actually. Okay. Next, question number 12. A newborn presents with increased umbilical cord bleed. PT is increased, APTT is normal. What is the likely diagnosis? Yeah, what is the answer now? Factor 13 deficiency. That is not the answer. Why? In this both PT, APTT, both of them should have been what? Normal in this case. Although this can present as increased umbilical cord bleed, but this is not the case. Vitamin K deficiency is the one answer. It is not DIC. It is not von Willebrand. Von Willebrand will not present with umbilical cord bleed. Umbilical cord bleed, remember, will usually present, will be a problem if there is either extrinsic deficiency or common deficiency, common pathway deficiency. Intrinsic pathway deficiency usually will not bleed from arteries after an injury, like after an external injury, like umbilical cord is an external injury, isn't it? Yes. So it is not DIC. Tell me why. In DIC, both PT and APTT should have been elevated. And DIC in a newborn, unless you are giving me sepsis history, I will not make a DIC in the newborn. Don't get confused. After child is born, mother can develop a DIC because of amniotic fluid embolism, not the fetus or not the baby. Unless baby had sepsis, neonatal sepsis, then DIC can be there. Otherwise, it's not DIC. And there is no other thing suggesting DIC. In fact, in DIC, both PT and APTT should be prolonged. And von Willebrand disease will be elevated, APTT will be there. And plus, I told you, intrinsic pathway defects were unlikely to present as umbilical cord bleeding. Now, in vitamin K deficiency, this is where is confusion. In vitamin K, what are the vitamin K dependent factors? 2, 7, 9 and 10 are the factors, isn't it? Yes, correct. So, you are expecting both PT and APTT to be elevated. That is right. You are expecting what? Both because 2 is common, 7 is extrinsic, 9 is intrinsic, 10 is common. So, you are expecting both PT and APTT to be elevated. Yes, correct. You are expecting both PT and APTT to be elevated. However, anybody, PT increases first, later APTT. Very good. Why PT increases first? And this is what is a question asked here. Why PT? Because factor 7, half-life of factor 7 is shortest. Because of this, there will be decrease in factor 7 first, followed by all other factors. And that is the reason why initially what will happen? Initially, only elevated PT can be there. As in this case, PT is elevated, only PT is elevated in this case. 7 has the shortest half-life. So initially only PT can be elevated. Isn't it? That is also the reason why. Acha, what drug do we use which inhibits vitamin K metabolism? Anybody? What anticoagulant which inhibits vitamin K metabolism? Which anticoagulant inhibits vitamin K metabolism? Which one? Warfarin. And for warfarin monitoring, what test do we do? PT-INR or APTT-INR? Which one is done for warfarin monitoring? Which is done? In this, immediate treatment will be what? Okay, treatment of this patient will be, I will give IV vitamin K 2 milligram stat. If not responding, if no response, then add FFP to the treatment. Yes, correct. For warfarin, we measure PT-INR. We don't measure APTT-INR. Why do we measure PT-INR? Sir, in warfarin, both PT and APTT can get elevated. But initially, which will get elevated? PT. Why? Again, same concept. First factor to deplete after warfarin also is what? 7. One more is protein C also has a very similar half-life like 7. And that is why warfarin can also cause thrombosis. Because protein C has a similar half-life as factor 7, which is also vitamin K dependent. So warfarin inhibits that also. Okay. Next. Question 13. Slide agglutination blood group of a patient is as follows. Which FFP can be transfused? Question is FFP. First identify what is the slide agglutination blood. Okay, they have not mentioned which is A, which is B here. Doesn't matter to us because both of them are showing what? Clumping. So if this is A or this is B or the other way around, doesn't matter. Usually the left side will be A, right side will be B. Okay. Yeah, that is why. Now what is the blood group? AB is the blood group, isn't it? The blood group is AB. Yes, correct. For heparin, we measure APTT. Correct. Yeah, blood group is AB. So if blood group is AB, which FFP can be transfused? Yes, tell me now. For AB, which FFP can be transfused? Answer is only AB. Only AB. If you remember your for blood, who is the universe blood? UD, UR I am writing. What is UD, UR? Universal donor, universal recipient. For blood, universal donor is O, universal recipient is AB. Isn't it? Yes. Now, for FFP, role reversal. AB becomes universal donor, universal recipient becomes O. So this patient is AB. You cannot give him, he is not universal recipient. You will be giving him only one AB. So either you remember this way or the concept way. The concept is, what is the concept? Yeah, RH we have not discussed. Okay, if you want to add RH, O negative becomes and AB positive becomes the universal donor and recipient if you are adding RH. Okay. Clear? Yes. So answer to this question only AB. Next question number 14. Question number 14. 23-year female presents to emergency due to road traffic accident. Which blood should be given to her in emergency? Which blood should be given to her in emergency? O positive, O negative, any RH negative, ABO and RH matched blood only. Yes, sir. Which one will you give? O positive, O negative, any RH negative, ABO and RH matched blood only. Okay. Option D ruled out. Why option D ruled out? We are talking in emergency. So in emergency, we can be giving which one? O negative, O positive. Very good. Answer will be option B, O negative. Same question, 23-year male if I give, is there any change or same answer? If I give male, then will there be any change or same answer? So if I give male, then you will write O positive, then don't write O negative. O negative, so in emergency, we give what? Yes, in emergency, we give O blood group. And in bracket, I'll write prefer O negative in women of childbearing age. So in men, we are not going to prefer what? O negative. In men, we will give O positive only. In women, we prefer. When I say prefer, that means what? Yeah. So if it is available, give O negative. If it is not available, even in women also, we have to give O positive because it is emergency. I don't give blood, she will die. Isn't it? Why male is different? Because O negatives is less. So blood bank will be running out of O negative. If they keep giving O negative to everyone, then blood bank will be out of stock for, O negative very quickly. And बाद में if female comes, and then you don't have O negative. Previously, we had given O negative to one male patient, and now female comes and I want O negative, it is already gone. So that is why we keep O negative reserved for females. It is saved for female emergencies. For males, we keep giving O positive. Blood bank people don't want to fight with clinicians. They will say out of stock for male patient. That's it. So they say out of stock. That's it. So you send a female next immediately you send a female request. They will give you O negative. Okay. Yeah. Next. Which of the following blood products ABO matching is not done? Achha, where you do not do ABO matching. ABO matching is not done for which? FFP, platelet, cryoprecipitate, washed RBC. In which one you do not do ABO matching? ABO matching, yes, is not done for cryoprecipitate. Even for platelets, we say ABO is not mandatory. What do I mean by not mandatory? ABO is not mandatory. It is done, but however, if you don't get ABO matched platelets, you can give ABO mismatched platelets also. That is what it means. But for cryo, we do not do ABO matching. Why? Cryo will be the solid precipitate at the bottom. The supernatant will have all the antibodies of the plasma. That is why ABO is not done in cryoprecipitate. ABO is not done in cryoprecipitate. Apart from cryoprecipitate, anywhere else ABO matching is not done. Anywhere else ABO matching is not done even in, yes, ABO is not done even where else? Cornea. Corneal transplant, ABO matching is not done. Even in hematopoietic stem cell transplant also ABO is not done. Otherwise, ABO matching is usually mandatory for blood transfusion, all other things of blood we discussed, and all the solid organs except for, cornea and hematopoietic stem cell transplant or bone marrow transplantation. We do not do ABO. So in question, if there were what? Question 14. So I didn't understand your question, Manav. Please tell me what is your full question. I'm not able to read, I guess, fully. Question 14. What is your doubt? If there were what? If we had known her blood group, if we had known her blood group, then we'll give ABO matched, RH matched blood, but uncross matched. Remember, in emergency we always give uncross matched blood. Male, if they had mentioned male, then answer would have been O positive there. If they had mentioned male, I would answer it O positive, not negative. Okay. Yes. Yeah. So these were questions from the predictor series. Do expect a lot of questions from WBCs and also transfusion medicine in exam. Any doubts, guys? So I see most of you have got good score in the paper. What is a good score in this? I would expect everybody to score at least 10 to 12. 12 is what I expect. More than 12 is good. Someone between 10 to 12, you need to improve. If you want to be in top 500 ranks in INICET, this paper you should have scored more than 12. Okay. Cornea point, in cornea and bone marrow transplantation, we do not do ABO matching. Okay. See, ideal will be O negative. Everybody wants the best thing, no? But you won't be getting best always. Ideal will be O negative. In fact, ideal would be Bombay negative if you want. The best will be Bombay negative. So you're not going to get Bombay negative anywhere. And even if they are there, we'll not give that. Okay. Okay, guys. Specific topics. I expect questions. WBC. Specific topics, no. Because INICET people are very smart enough that they will not, go by topic. But usually when they ask a topic, they will be having multiple questions coming from that topic. So sometimes there will be more question on diagnosis, sometimes there will be more question on treatment, sometimes there will be more question on images, sometimes flow cytometry or such things will come. So but it will be coming. WBC, definitely yes. Iron deficiency, megaloblastic anemia, definitely yes. Hemolytic anemia, sickle, thal, and G6PD and hereditary spherocytosis. Okay. Best wishes, guys.